The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Okay, everyone, welcome to part 2 of my conversation with George Stylian. George has kindly taken some more time off his holiday to join me today. So we'll continue where we left off during the last episode. George, we had a discussion on part 1. We mentioned a lot of things regarding the foot and its implications in osteopathic practice and osteopathic, approach to treatment. Give us some more insight, mate, onto how you've looked at this phenomena and how you've been able to unwind some of the somatic dysfunction, some of the conditions that you've seen in your clinic.
Yeah, well, as I mentioned in part 1, we talked about the importance of barefoot walking in relation to what we prescribe when we prescribe the insoles as well. You know, that's part of it. And the way that the insoles work is you have to walk, you have to create this oscillatory input to the nervous system with that the signal gives, which is basically bringing the ground to the big toe so that it doesn't, supinate and flex during toe off. So when we walk in shoes on a flat surface, okay, muscles are being used, but what is not being used is all the little muscles of the foot. But when we're working on uneven terrain, we're employing all those little muscles, the small muscles of the foot, and they're part of what gives the foot its integrity. So that's another reason for barefoot walking, is we recruit those muscles that we don't recruit, when we're walking on a flat surface in shoes. And the other thing I highlighted was the importance of looking at the relationship between the navicular and the cuboid and the calcaneus, and how the calcaneus, a lot of the times, in the non-weight bearing patient, is actually stuck in inversion, and there's no. So, eversion, inversion, like the definition of pure inversion and eversion is a 5-degree lateral motion of the calcaneus. So you hold the lower leg, right? You stabilize that, and then you move the calcaneus it's got to move 5 degrees in a lateral motion one way or another. That's what the books classify as pure inversion and eversion. Because, the cuboid is the keystone of the lateral arch of the foot, and the navicular, the keystone of the medial arch of the foot. The other thing that I wanted to mention was that humans are the only primate, we're the only ones with an arch. No other primate has a foot arch. But we evolved a foot arch because we became runners. The Australopithecines, they were walkers. They were easy prey. But when we became runners, we became the hunters. So, that's why we've got all these, long, slender tendons that make the foot act as a spring. Gave us the ability to run. And of course, that gave us the ability to escape and also hunt. So, my argument is that if, we evolved to have this, unique structure, the foot, and it acts as a spring and a shock absorber, why do you put something rigid under it? It doesn't make sense.
So let me push back a little bit on that. You mentioned that the intrinsic muscles, the little lumbricals and the not the lumbricals,
Yeah,
sorry, the muscles in between the bones of the foot, they're quite important in stabilizing the foot
yeah,
and
the
also foot
lumbricals, the
function. That's right.
interossei muscles. Yeah,
Yeah. So, and you said that in walking on uneven surfaces, they become very important in terms of allowing the foot to kind of shape to the surface and getting good traction and so forth. The argument, I guess, also is that our feet have evolved for uneven terrain because
yes,
for the large part of the human existence, we've been walking and running on uneven terrain. It's only in the last 100 or so years that the terrain has become 95% flat, 99% flat. And so even if you're barefoot walking, you're still walking on an even surface. Would you agree with that, George?
yeah. So like when we go walking on pebbles and in the sand, our foot,
Hmm.
sinks into the ground, and of course we have to
Yeah.
recruit all those little muscles that, you know, propel us.
Hmm.
Uh, yeah. So
But most people aren't walking on pebbles and sand every
no,
day in their life. They're walking at
no,
home on
yeah,
tiles, on flat surface, out, if
yeah,
they're walking outside on the grass, it's flat surface. And
yes.
so the foot has evolved to a certain landscape, but the landscape's rapidly changed in the last 100 years. Do you think the foot's caught up to it?
Well, I mean, I don't know, to be honest with you. I don't think, evolution takes, I think it takes a lot longer than
It
100
does.
years to
Yeah.
change,
Do you
the
think
same.
that's why we see a larger phenomena of, medial arch collapse, the keystone collapse of the navicular and of the cuboid on the lateral arch and the navicular on the medial arch? Do you think there's a higher phenomenon now than would have been? But I mean, yeah, like my contention is that the foot isn't the problem; it's the surface that's the problem. The surface has
That's,
changed.
yeah, exactly right.
Yeah.
And this is what, Dudley Morton was talking about, back in the 20s and 30s. And he
Mm.
published a lot of books for the public, apparently, um, you know, giving them foot exercises,
Mm.
strengthen their feet, because he was against the idea of rigid orthotics as well. He thought,
Mm.
we've got a functional problem here. Let's find a functional solution. If
Yeah.
you've got an orthopedic problem, it's fair enough. You've got to have a foot orthopedic solution, like
Mm.
sometimes like a rigid boot or something, in order to keep things into
Yeah.
place because it's too far gone. But we've got a functional problem.
Mm.
So there are so many functional ways of now addressing those problems.
And do you think though that I mean, let's talk about the traditional type of orthotics that you would see. Um, I've seen good orthotics and I've seen very poor ones, and I find that the ones that are built up quite heavily, especially along the medial longitudinal arch, tend to do the most damage. And you see the patients; they walk in like cowboys on the outside of their feet. They've lost that spring on the underside of the plantar surface of the foot, and that usually ends up presenting in my clinic in some kind of disc prolapse 6 months down the track. Um,
Yeah,
that's been my experience, and I've seen good orthotics, and I look at a good orthotic, and it's not very heavily built up, and there is still the poly that's being used is a lot thinner and still has a lot of give in it. And I found that they've worked well on certain patients, and also I find that the strengthening part of the foot, whilst it's a great idea functionally as a solution, how can I say this? I don't think people are invested in doing these little exercises, all the time and having that kind of, picking up a pen off the floor with their toes and curling their arch up and doing that. They tend to look for a quicker solution.
yeah,
And
that's
so that's where orthotics have come
the
into play. But I find that there are good orthotics and there are poor ones. What's your take on it?
yeah, I agree. I mean, um, as I told you last time we spoke, my personal experience drove me to look for an orthotic that
Mm,
actually worked. And I tried various avenues, and then I found this simple one that Professor Rothbard, you know,
mm.
created that was very simple, in relation to other orthotics, very inexpensive, easy to fit. You can, diagnose and fit on the same day, and it's not time consuming, and they work. I mean, we guarantee ours. We say to people, wear them for 30 days. If you're not happy with them, bring them back and we'll give you your money.
Mm. And just to recap, that the idea behind that particular orthotic is it raises the floor underneath the first metatarsal.
Yeah, so what it does
But
is just
yeah,
brings the floor up to the first metatarsal, because what Dudley Morton said many years ago was that the falling of the medial arch was related to the first short metatarsal. And what Rothbard talked about was that is related to the intraosseous unwinding of the talus during the first 10 weeks of embryological life. If the unwinding is not complete, then the first ray does not get as long as the second ray.
right. So
And what that does, and I mean, Rothbard called it, supernatus, the primary, sorry, that the first ray goes into supination and flexion. But what I found in practice, I mean, it may look like that, but the reason why that is happening, because the first metatarsal is short, it actually drops on the first cuneiform. And that's another thing that, people should really look at. And it is sometimes the cause of foot pain as well. But that is a really common finding when the first metatarsal is shorter than the second, that the first metatarsal will drop on the first cuneiform. So, so those things should be really, be addressed in any patient really with low back pain.
yeah,
Because it's
George,
going
when
to,
you
so to recap, the things that are really important to look at that are commonly, out of place in a foot are the calcaneus, lost its eversion, the cuboid, because once the canal goes into inversion, then the cuboid is going to lose its relationship with the navicular. There's a little shelf that exists between the navicular and the cuboid that holds that makes the arch, complete from medial to lateral. And of course, when the cuboid goes, then we get a lot of patients coming in with pain in the fifth metatarsal, but the problem is the cuboid. That's why they're getting the pain in the fifth metatarsal. And then you've got the relationship between the first cuneiform and the first metatarsal. Those are areas that are commonly in what we call, lesion in the old days, the osteopathic lesion. Those areas are very commonly strained in most patients. So, and it doesn't take long to make some difference. And the anterior talus, because so many people are so tight, between, that fascial continuation of the thoracolumbar fascia, ischial tuberosity, all the way down to the calcaneus. So when that gets tight, it's actually going to drag onto the under the thoracolumbar fascia as well, because that's where it kind of anchors itself.
Yeah, so the treatment obviously follows all the way up the chain.
Yeah.
I want to ask you, when you see patients in your clinic, and particularly now that you're practicing, are you still taking a fairly structural approach to alleviating, foot problems, or do you still use a fairly structural approach to moving tarsals, moving talus, moving calcaneus, or are you,
I use many tools of the trade. I use balance ligamentous tension. I use mobilization. I use inhibition. And I also use MET, especially
yeah,
for the anterior talus. And so I use a combination of MET, mobilization, and stretching for, for the whole lower limb from, all the way from the pelvis down. I'll use that approach. And in, young children, for instance, I'll use fluid drive, from connected to the to the lumbosacral area. Yeah, because when I did some work with Jim Jellis, he was talking about how the embryological fulcrum for the upper limb was C7 and for the lower limb was L5. And I spoke with Brian Freeman about that, and I wanted to take on what he thought. And he said to me, look, anything needs a blood vessel and a nerve to grow. First, we have organized fluid, and then that starts the process. That starts a functional process. And in order for that to become a structure, it must have a nerve supply and a blood supply. So the embryological fulcrum for the upper limb, he said to me, is the brachial plexus and the brachial artery, and that for the lower limb is the lumbosacral plexus and the femoral artery. So what I do with infants and children, when I dress the lower limb or the upper limb, I always have one hand on the embryological, fulcrum, and the other hand on the part of the limb that I want to treat. So if they've got, say, like a knee injury, then I'll connect the lumbosacral plexus with the knee. If a foot, down the foot. And, I also use that with sciatica because, you want to try and get both nerve flow and blood flow, into the limb that's been affected by any spinal problems too. So,
Yeah, right.
yeah.
Okay. All right. So,
To answer your question, I used all the
yeah.
tools that I've learned.
Yeah, I was just trying to maybe get an understanding of if you found that, look, the way I look at it is that when you're working at the foot, because there's such a long lever from the foot up until the pelvis, thoracolumbar, it's a long lever there, so you can really make
Yes.
quite rapid changes just by moving something quite. You don't have to move a lot. You just got to get the function back into a certain area. And because the lever's so long, it makes a big difference to the pelvis. It makes a big difference to thoracolumbar. It makes a big difference all the way up the chain. And so, it doesn't have to be, it could be a quick MET or an adjustment to the foot or some kind of articulation to the fibular head, whatever it is. And I was just trying to gather if obviously you've taken your work more into the OCF field, and you're doing a lot of that. I just wanted to know whether, when you look at, say, the foot and some of the problems, are you still using some of the good old structural techniques that you learnt when you were, when you were starting out, if you're still kind of practicing that way? Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you, and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
Well, yeah, the other thing that I forgot to mention that's really important when working with the lower limb is the interosseous membrane. So, because of of its relationship to the nerve supply and blood supply to the foot. So, I could use a BLT, but a lot of the times I use mobilization, just get things moving and trying to equalize the range of motion in all the directions.
Yeah, definitely,
Yeah.
100%. Yeah, I want to move on and just ask you a little bit about what you're planning on discussing at the. I know that you're doing the Osteopathic Summit in 2026. Is that correct?
Yeah, I've been invited to talk about that, and because Shane knows that I've been working, with a dentist, he wanted my approach. Well, the theme is going to be about the lymphatics. So I'm going to talk about the lymphatics of the face and of the teeth, especially in relation of the lymphatics of the teeth in relation to the thyroid. And to me, that's really important because I've treated patients who have been diagnosed with so-called, thyroid disease related to autoimmune, cause, and all I've done is got them to take out their amalgams and go on a detox diet and the thyroid, a mercury detox diet, and the thyroid problems iron out.
Yeah.
Because the lymphatics that drain the teeth, they join the lymphatics of the thyroid gland. So if you got any, poison, like infected old root canals, like a root canal, most probably got a lifetime of 10 years. After that, it starts to get a low grade, anaerobic infection. Where is all that poison going? It's going to your thyroid. So, so cover some of the innovation as well is really important, because the innovation to the veins is from the middle cervical ganglion, and the old osteopathic books say that when we're dealing with thyroid problems, we've got to look at its drainage, because it's got a really rich blood supply, so the blood gets there. There's no problem with the arterial blood getting there.
Yeah, just got to get it out.
Yeah, we've got to get it out. So, doing the releases through the anterior cervical fascia and also down through the midline, is quite important. And then you've got your lymphatic, techniques.
Thoracic duct and
in the thoracic duct. And there's various ways of doing that. So, and also, looking at the carotid sheath, because the deep cervical lymph nodes actually are within the carotid sheath, together with 9, 10, 11, and vagus and internal jugular veins. So it's right underneath the sternocleidomastoid. So all this anterior group, the floor of the mouth. So we release all that and we get the drainage happening. Obviously, you have to open up the thoracic inlet. I do that with just about every patient.
Yeah. So I guess that's what you'll be discussing.
If I'm going to move blood from the lower limbs, or if I'm going to move blood from the cranium, if you've got a restricted cranium that's affecting venous sinus drainage, where has it got to go?
Well, it's got to
You
go
got to,
down, and if there's a restriction there in that
yeah,
cervical sheath, it's not going anywhere. It's staying up
yeah.
there.
So,
It's the same with sinus. It's the same with congestion, and
yeah,
it's plumbing, right?
yeah, yeah,
Yeah. All right. Well, I guess that if people are interested in that, that's the Osteopathic Summit 2026. I think they can go to the website Osteopathic Summit. I think it's .com, osteopathicsummit.com.au.
yeah.
That'll be
Well,
in Byron Bay. Is that correct, George?
the Osteopathic Summit is going to occur down at the Mornington Peninsula in Victoria.
Mornington Peninsula, right? Oh,
Yeah,
wow. Okay. Good
yeah.
destination.
It's a pretty
That's
nice
a reminder. I
resort.
mean, even I remember back in the day when osteopathic conferences that the Osteopathy Australia or the Australian Osteopathic Association used to run, they were in quite nice places that we used to go to back in the
Yeah,
day,
that's right.
and
Yeah,
it's good to have that kind of hands-on approach that's led by osteopaths too. I really like that. The fact that there's a
yeah.
conference that's for osteopaths by osteopaths, and we're seeing so many people now come into the conferences that are experts from outside of osteopathy, and I think we've forgotten how rich our wealth of knowledge is within osteopathy. That we need to really get back to
Well,
promoting that as well.
well, what Shane and Natalie have tried to do is get, the osteopaths that have been practicing for more than 30 years or so
Yeah.
so the most of the speakers will be, people similar to me that have been in practice for about 40 years or more.
Hmm.
And
Yeah,
yeah,
that's very good.
so,
That's definitely
so,
what if anyone's looking to kind of reignite some fire under their backsides about osteopathy, that's a good place to start.
yeah,
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 George, I want to move on and speak to you about I guess some of the issues that you've had in the last few years regarding the time around COVID and what you were involved in and some of the regulatory issues that you've had. We've spoken off camera about this, and basically you were involved in I guess a conversation to have a look at a new or not a new organization that's looking out for the traditional osteopathy. And you'd mentioned that to some of your colleagues that were also interested, and
yeah.
then you had some regulatory issues that came up due to some complaints. Do you want to fill us in on that period of time? What exactly happened? Do you want to clear the record for us so that people understand how the regulator had proceeded in your particular case?
Yeah, sure. Well, during 2021, 22, there were a lot of osteopaths saying that, we need an alternative um, group or organization or society that
Alternative
supports,
to what, George?
alternative to Osteopathy Australia.
Okay.
Because a lot of people felt like Osteopathy Australia wasn't really looking after their own interests, especially when it came to the mandatory vaccination that they were, trying to push on every practitioner. But the other thing is they didn't feel that Osteopathy Australia was really, uh, supporting traditional osteopathy.
Right.
And also, osteopathy in the cranial field. And of course, when COVID hit, these same people became even more interested in forming an alternative, society, let's say.
Did you feel the same way, George? Did you feel the
Yeah,
same way about the association, about
I felt
Osteopathy
the same
Australia?
way.
Yeah.
I felt the same way. I stopped being a member. Uh, I don't know. It's been maybe 20 years or so.
Mm-hmm.
Yeah. But
Right.
anyway, the
Yep.
thing is, so this was like, an osteopathic group, right? that we're exchanging ideas and emails, face to face. So, like I said, um, by by emailing each other ideas and I don't know, somehow the word got out and some New Zealanders starting emailing me and said, "Oh, look, can we join too?" Because we were going to look at calling it the Australian Traditional Osteopathic Society, and then they wanted to be in on it, and then we were going to call it the Australian New Zealand Traditional Osteopathic Society, and
How many people
so
roughly, George? Like when are we talking a few, people mentioned, like how many, if you could you give us a rough estimate of how many people that you think would have been interested in joining this society? Like what are we,
well, I
like
mean
given your
the
estimates, do you think you
uh,
would have got 100, 200 members, 50
well, I
members?
mean I it didn't eventuate to
Hmm.
the point where we could you know get it out there. First, what we were trying to do was establish, what was going to be the aim of
Hmm.
the of this society. What was the structure going to be like?
Hmm.
And of course, we all agreed that it should be a democratic structure, that everybody should have an input, and and everybody should be listened to. Um, so we were still kind of trying to get that in place before we actually put it out there to the rest of the profession. So
Just to
I
give
will,
some context, George, before you go
that,
on, I think, yeah, I
yeah.
do want to ask you this. How involved were you with the original setup of the Australian Osteopathic Association? Take us back to the days of Avan and maybe negotiating with the Victorians. Was that something you were involved in? Were you around at that time?
Well, I
Um,
was around at that time. I was involved in the um, with the use. Well, at the time there was there was two groups in New South Wales, and one was led by Alan Griffiths and the other one by Ivan.
mhm,
So Ivan's group was called the United Osteopathic Physicians Guild. In in Victoria, they had the Australian Osteopathic Association.
mhm.
So what was decided, after meetings of the professions, so of the two groups, the New South Wales and
The
Victorian group,
Victorians. Yeah.
because that's where most of the osteopaths were, was in those
Mm.
two states. Decided that we call it the Australian Osteopathic Association.
And you were a part of those meetings? Were you involved there? Were
Yeah, of course I
you
was. Yeah,
right?
I was part of the
So
meetings.
just the reason why I wanted to give people context, it's like this is not new to you, George. It's not like you're
Oh
trying to,
no,
you've been a member of the profession, an involved member. Somebody has helped get the Australian Osteopathic Association kind of find its feet. You've also been involved with the various cranial associations that have come up as well. So
yes,
it's not like you're trying to, hamstring osteopathy, and you actually
no,
wanted to make sure that the traditional tenets of osteopathy were quite rightly protected. Is that correct?
yes, of course. I mean, I was acting in the best interest
Hmm.
for osteopathy. So at the time, I was the chairman of the educational committee of the United Osteopathic
Hmm.
Physicians Guild. Then later, when we amalgamated and became one association, the Australian Osteopathic Association, the there was a research component to it, and a lot of us, volunteered uh, to be part of that, and a lot of us also gave funds,
Hmm.
and when we actually got our own building over the north side of Sydney.
At the building in
And
Chatswood that they're currently in at the
yeah,
moment?
yeah. So actually, we raised enough money to actually buy that,
Hmm.
and we had an open, well, it was an open night really for that building. And Ivan was there, and Ivan had donated, his yearbooks and a lot of other, books to the association. Uh, at the time, uh, Robert Fendel was the president, and he wanted us to establish a library.
Hmm.
So I became like the librarian of the Australian Osteopathic Association, and I started, bringing in convocation tapes from the American Osteopathic, from the American Academy of Osteopathy, their
Yeah.
convocation tapes, yearbooks, journals.
Hmm.
And so, we were actively involved in doing that. Um, and Yeah, well,
All
and
right.
then, we
So,
had Anthony Robbins
yeah.
was really, fighting for osteopathic rights. Yeah, we kind of got together and we wrote letters regarding the unfair treatment that the osteopaths got when it came to insurance rebates, because they didn't consult the osteopathic profession at all. They consulted physiotherapists, and physiotherapists, 20 plus years ago, the way they worked was, they had 3, 4 rooms going all at the same time. And of course, the rebate was very poor compared to osteopaths who were only treating, one patient at a
Hmm.
time. Our fees were, of course, different. So, we wrote letters to the politicians and stuff like that. So, yeah,
Right. So you're somebody who was actively involved in setting up and not only setting up but also funding out of your own pocket.
yeah, well, I
The
mean, on that open night, they had a plaque on the wall,
Yeah.
right, at the entrance there, and it had the names of all the people that
Hmm.
donated money to the association. Guess whose name was on the top?
Right. Okay.
Right.
Well, the point I'm trying to make is that you're actively involved in that. You funded it. The current building that Osteopathy Australia has its headquarters in, you were quite instrumental in setting up, funding, donating
Well,
that.
yeah, well,
You know,
it was also, I mean, the building was bought on funds that were raised
that were
by
raised. That's right.
membership.
Yes.
We became members and we paid a price to be members, and all that
Mm.
money was being, saved and used properly. And eventually we got our own building.
Right. And that's where the current Osteopathy Australia is
Yes,
working out from, the same association that you feel no longer represents you, George. Would that be correct?
yes,
Right. Okay. So fast for now. I just want to give people context around this, so they don't think that you're somebody who's just woken up one day and going, "I'm not happy with this," and you want to start your own thing. You've been around the block. You've seen the beginnings of really an association, a professional association here in Australia, and you were instrumental in it. And now that you feel that this association no longer represents the things that you stood for, you had an opportunity to, I guess, not even start something, but just make contacts. So now you've made contacts, you've sent some emails around. The New Zealanders are interested in the traditional society of osteopaths that you were looking at establishing. Word got out. What happened then, George?
well, I mean, we so anyway, I got um, contacted by the the health ministry. They handed the matter over to AHPRA. There was a complaint against me, obviously, because they felt that I was unsafe to the public. And this is what they accused me of. And then the health ministry, they passed that on to AHPRA, and AHPRA passed it on to the Osteopathic Council of New South Wales.
Right. So why did they feel that you were unsafe? What was it about? I mean, just starting society by itself isn't. I don't think is an unsafe practice. Why did they? Was there anything in the paperwork that they didn't like? Was there something? Was there any evidence
Well,
that they had?
there was something about, well, I was, my conduct was unprofessional, and there was a threat to the public, and they quoted some national law with a number or 139 something, and and but it had nothing to do with the patient. I
Right.
was, and it had nothing to do with the public. And they
So,
took one
yeah.
email out of the several emails. So, like, if we looked at the last email, for instance, what we had started off with, like we started off with 7 different aims that
Mm,
the society will look at, and education and research was one of them. And one of the things that we really wanted to do was like use you know science to show that traditional osteopathy is still valid, because a lot of people in our profession feel that all of the AT still stuff is outdated, it's rubbish, it shouldn't be taught. Whereas, a lot of us feel that, A.T. Still was a genius and that he
mm,
was really well ahead of his time. And, so many of his students, that came on after him, they had the same passion of trying to convey to the profession that, the richness and the uniqueness that osteopathy has.
mm.
You know, it's its whole medical system. It, you know, um, and this is why I hate the thing. We're allied health professionals, and we're like complementary, and it's like,
Mm.
no, we're not. We are a unique profession.
You feel like
People,
osteopathy stands on its own 2 feet as a
yeah,
system of
that's right.
medicine.
Yes,
Right.
yes,
Right.
and this
Um,
was another. So, these were things that we were talking about. And the other thing, obviously, was that we felt that, we were not represented or protected by our profession, because they were forcing us to get vaccines, which were, first of all, experimental. They were based on mRNA technology, which got completely,
mm,
uh, dumped by the 1980s. Robert
mm,
Malone, who came up with mRNA, he was Dr. Robert Malone. All you have to do is Google him and listen to him say what mRNA vaccines did to the experimental animals. They either died
mm.
or they got sick. So they abandoned the RNA research because the 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 findings were that they were negative to health.
Mm.
So here we had, and a lot of us knew this because a lot of us were doing our own research and looking at, you know, a lot of medical experts like, McCullough, for instance, you know,
Peter McCullough, you're talking about?
yeah, and all of these doctors were not against your traditional vaccines.
Mm,
They were pro traditional vaccines.
mm,
They were not against them, but they were against this type of vaccine because they knew it would do harm,
mm.
right? And we were being forced to take them, even though they had not been researched properly.
George,
They just
is your issue is your issue? Sorry to cut you off. Is your issue with the particular vaccine or with the fact that they were being mandated onto osteopaths?
both,
Both. Right.
right? Um, well, up until COVID, it was a criminal offence to push anybody into a medical procedure without their consent.
Yeah.
So basically, they took our consent away, and they
Mm,
were punished us. Well, I mean, so there goes democracy, there goes free speech, there goes choice.
Yeah.
I have the
Look,
choice. You know,
I'm gonna play devil's advocate for a minute.
yeah,
I'm not totally unsympathetic to your position, but I'm gonna play devil's advocate for a minute and say, you know, I guess stakeholders of the profession, whether it's universities or the association, the current Osteopathy Australia, or whoever it is that has an interest, I guess, in osteopathy, they might feel that the regulatory standing of the profession might come under threat if we don't toe the line, and if we start, if we start ruffling feathers, we might cop the same, treatment that the chiropractors copped a few years ago when they were, treating babies, and that was all on the media. And so there's a bit of a fear there, and I guess the argument might be that it's best to go unnoticed rather than to kick up a stink and have some kind of regulatory hammer come down upon you. That might have been the approach or the thought process of people who, I guess, were in charge of advising the profession. What do you say to that?
well, what I say to that is that it's a big cop out. To me, it's not about what they were trying to force us into. It was about our patients. You know, how about our patients? Where do their rights go? Aren't we supposed to be acting for the benefit of the public? I mean, I thought that was our job.
Yeah, that they would argue that not that advising against taking COVID vaccines would be detrimental to the public health. That would be their argument. The hindsight of this whole thing is that that's probably an incorrect position, but at that time, hindsight wasn't available. Are you somebody that would say that, now that I mean, you probably have the same position now that you had back then, but given
Yes,
the
I
fact
do.
of hindsight, would you say that, would you be more, I guess, sympathetic to that position at all, or is it you still kind of stand by your
Well, I
position
mean,
that, at the time, there should have been some more freedom of choice?
at the time, if the whole osteopathic profession got together and acted as a unit, you know,
Mm.
with a single purpose, then we could have had an impact.
Mm.
But of course, you know, it, people running the show didn't feel like that at all.
Mm. I don't think there's unity in the profession on that particular point, George.
No,
Whether I
no.
agree or disagree with you, mate, I don't think there's unity in the profession on those things. I think though you're right. There would have been a lot of. I know I've had people contact me. I know people that have actually left the profession based on the actions of whether it's the association or whether whoever, just the broad profession. They've left the profession because they feel like you said, that a lot of practitioners and a lot of representatives copped out. They just took either a position that was neutral or a position that was towing the line of the recommended procedure at the time. And so, yeah, people have approached me and they've said, we're no longer part of the association, or we're no longer part of Osteopathy Australia, because we feel like when we dissented against the advice, we were shut down, we weren't listened to. And I think just looking at the financial records of Osteopathy Australia, in and around that time, there was a 25% reduction in membership in those years at the end of COVID and during COVID. So that's a big drop off in membership when you
Yeah,
think about the impact on the profession. And so, yeah, I think you're right. People were a little bit hard done by, and they feel like that the association didn't represent them. And I guess they might have been sympathetic to what you were trying to do with the traditional society. Would that be correct?
yeah. Well, I mean, so yes, that's correct. They wanted an alternative, but they also wanted to produce a voice, an osteopathic voice saying that, we don't agree with this because we don't feel that this is safe, what you're doing, not only to us, but to our patients.
Yep.
Because we weren't just concerned about ourselves, I mean, we wouldn't be in this profession if we didn't care about the public and about our
No,
patients.
no, you're
Yeah,
right. Definitely. I mean,
you know,
everyone
not
gets
only
into
that, I
osteopathy to
mean,
help.
and not only that, I mean, you got kids and grandkids, you're thinking about them as well.
Yeah. 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 No, you're right. Yeah. Look, my particular position, I think there should have been a lot more freedom of choice, and I think there should have been some more robust debate. The problem is that, again, I mean, what you were trying to do, that got out and the regulator came down pretty hard. Can you imagine if the association had taken a stance? They would have probably had some blowback. But again, your particular point of unity would have been important. But mate, I just don't think that the profession is united on this particular thing. I think there's a lack of unity on it, and it's probably a space for discussion. I think now that we have hindsight, it's somewhere we need to look in terms of having robust discussion. It's a play, and I think it's a particular area that osteopaths can lead if they really want to. But I don't think that discussion will happen between you and me and all the
Yeah, but
listeners.
the other thing that I want to stress is that my intention of being involved in creating such a society, if we did create it, and I knew it wasn't going to happen because I was going to take the lead. They expect me to take the lead, but I wasn't going to do it for two reasons. One, I didn't have the time, and second, I didn't want to make it look like it was about me. I didn't want
Right.
that. That was not my intention. And the other thing that has to, we've got to be clear about this is that the intention was not to form an alternative association or society that was going to go against Osteopathy Australia.
Right.
Right? Our intentions were not, if anything, our intentions is to unite everybody, is to bring everybody under the one banner, and I, like I've got, colleagues who get offended by being called cranial osteopaths, even though that might be their main modality. To them, it's like, no, I'm an osteopath, right?
Yeah.
You
Yeah, I get it.
understand what
Yeah,
I'm
of course
saying,
I understand. Yeah.
right? Yeah,
Well,
like we're all osteopaths.
it's like
It
calling
doesn't matter
I'm a
what you use,
structural
mate.
osteopath, or I'm a structural
No,
osteopath, or I'm a cranial osteopath. Yeah.
yeah,
I
that's all rubbish. I mean, how can you separate function and structure? I mean, how can you be a structural osteopath and not affect function? Or how can I be a functional osteopath and not affect structure?
yeah.
I mean, those terms shouldn't even be used.
Yeah,
It's
no.
thrown out of the front. We are osteopaths, full stop.
Yeah, I
That's
think
it.
listening to you, I think there are some other motivations of obviously having a look at this society. I want to discuss maybe one motivation with you. You've been heavily involved in postgraduate education. Where do you think? I mean, you said that you don't align yourself with what, say, Osteopathy Australia is doing in terms of protecting traditional osteopathic values. If you were in charge of what's going on, how could an association help, I guess, re-establish traditional osteopathic values within education? Like, what could they do to help bring that back?
I think they could do something similar to what the Fit for Practice group is doing. They get, again, osteopaths that have been out for many years and who have a certain, bend to different methods of applying osteopathic treatment,
Hmm.
and they get different people, right, to present. They present practicals and they present,
Hmm.
osteopathic principles and philosophy, anatomy, embryology, physiology, you know. So
Do you think all those things are lost on the university system, George? Do you think, I mean,
yeah,
what you just, do you think
well,
that they're lost?
yeah,
Would you give up on the university system in terms of trying to teach all that stuff? Or do you think that, some, at least traditional osteopathic philosophy, do you think that could be maybe encouraged in our university debate within osteopathic
I think
courses?
so. Yeah, you know, I mean, what really got me into trouble with you know the complaint was I think people got bent out of their noses got bent out of shape because I stated the original charter of osteopathy,
Right.
right, which stated that you know we don't use vaccines, we do not use serums, we do not use drugs, and we do not use surgery unnecessarily, and we don't use any other methods because if we did, that would really not, would dilute osteopathy.
Hmm.
Okay, so don't you think that everybody should know the history? And I think that's what offended people because that was the original statement, or the original charter of osteopathy.
Right. But you weren't saying, were you saying that you wanted to go back to that charter, or were you just using that as a
No, I was
as
just
as a
using
tool
that
to spark
as a
debate
tool.
about where we move forward?
Yeah, and of course, that charter was the original charter was because at the time, the drugs that they were using in America were actually harming people.
Hmm.
Like now we've got sophisticated,
Hmm.
medicines that help people, that save lives. So, you know, um, so we can't deny that.
Yeah.
Right? We're in a different era now. We're like 200 years down the track. So, but there's nothing wrong with stating
The
historical
history.
fact.
Yeah, definitely.
That was a historical fact,
It
and
seems
that
like they've taken that text and they've just used that against you
yeah,
in
well,
its
this
in
is it.
its
It's
literal
like
sense.
I didn't create the osteopathic charter. I just
Hmm.
repeated something that was very important historically.
Yeah.
Basically, I was trying to you know to to emphasize our roots and that you know and I still believe that we shouldn't be using drugs unnecessarily. It's
Hmm.
about use and misuse. You get somebody with pain. So what? People come to us in pain. We say, okay, look, don't worry about it. Why don't you just take Panadol and I'll take the steroids and you'll be right. We don't do that
No.
because we know that that's not the answer. That's just a symptomatic, you know. Um, and sometimes you need it. People in excruciating pain need some pain relief.
Yeah, definitely.
So again, it was taken out of context. So um, anyway,
So
I
where
think
did things move forward, mate? So the complaint was
getting back to the
made.
university system.
Yeah, sorry. Go
Yeah,
ahead.
getting back to the university system, it's been so influenced by the Friends of Science
Hmm.
that some universities are now taking out. They've taken out visceral osteopathy. They've taken out OCF and
Yeah.
a lot of the functional methods. And I see like from summer school and when I moved up to Byron and I started teaching with Alexandra Kulak and Julie Streckfus, and we were getting students coming. We had student rates, so we're getting students coming from the 3 different universities, and so many of them saying we've never learned anything like this.
Hmm.
We've never been told anything, like even just some of the basic principles and philosophies and the old procedures that we were taught.
Hmm.
You know, hardly any
Yeah.
of the
It's
young,
lost on them. It's lost on them. It's a
like
shame.
even the general osteopathic technique, they didn't know it.
Yeah. Yeah. And so do you, like I said earlier, do you think there's it's a hard one. Like it's not just Friends of Science at the moment. It's also It's also I guess some of the cultural shifts. Students who've been taught things like, subjects that deal with different cultures and how to talk to people and how to communicate and so as you put stuff into the courses, you've got to take stuff out. And what they're taking out is all the traditional osteopathic stuff. And so you've got this kind of like bland medical student that's graduating that doesn't really is osteopath by name only rather than by profession. And that's a shame. I don't think I don't want to, like that's a shame for the students. Like they deserve more than that. They're
Yeah.
paying their
Yeah.
fees, and it costs a lot of money to go to university these days. And you pay to become an osteopath, not I guess, just by title only. Um, George, what was the result, mate, of the regulatory action that was taken? What happened? And yeah, what happened with all that?
In the end, after having a meeting with the Osteopathic Council and their solicitor, they deemed that I was safe to continue practicing.
The funny thing for me is that the AHPRA is there to protect the public. I understand that bit, and I've done some work with the council, so I understand where the council's coming from. Um, Hello, everyone. Just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes. So, for more information, please see the show notes. Now, enjoy and back to the show. There was no. I mean, it's not like you emailed patients, did you, George? It's not like you sent out emails
No,
to
but
patients,
this was a closed group that was trying to put something together.
right?
So the emails were, within the closed group. They weren't, splattered over Facebook or
So
anything
you
like
weren't
that.
you weren't even sending like anti-vaccine messages to your
No,
patients. It wasn't
no,
that. So
no.
it's really hard. I mean, I'm trying to figure out the complaint. Like, you know, a member of the public would have to complain, and seeing as the public weren't aware of it, it seems like somebody must have complained from either within the profession, um, or yeah, somebody's got a wind of it. That would
Well,
be
it
my
must have been within
particular.
the profession because it never went outside a group of osteopaths.
Yeah, well, that's yeah. If it was in the profession, that's a bit of a shame. That probably the right thing to do is to
Mm.
give you a call and have a chat to you about it if they weren't happy with it. But anyway, okay. So basically, well, I could see why the solicitor of the council would have kind of said to you, just keep doing what you're doing. You're pretty safe because ultimately, if they did ever pursue it, there's no complaint against you from the public.
No.
No, that's a weird one. All right, well, mate, thanks for sharing that. I know that's not a lot of people would care to share their experiences with AHPRA, and thank you for doing that. Um, I want to give you the final word before we wrap it up. If there's a message out there that you want to give to, I guess, early career, younger osteopaths, even osteopaths that have been practicing for, say, 10, 15 years, what would be your message to osteopaths out there, George? Like, if you were to kind of give a message to people from somebody who has been there from a really early day, what would be your message to the listeners?
Well, I'll give him the same advice that I was given. Um, I knew this very old wise lady, um, and when I must have been, back in the mid '80s or so, and I was talking to her you know, about cranial osteopathy, And I said, like I think I want to pursue this, So I was giving her some background, and she said to me, if you are going to pursue it, make sure you read the founders, not those who came afterwards. Go back and read the founders.
Okay. Good advice.
Because that's where the essence is,
Yeah.
right? Not
Yeah.
a watered down version. Go back to the essence. Because once you grasp the essence, then, you'll find out whether you want to pursue it or not.
Yeah. Great advice. And I guess one more question I'll ask you. What would it take for George Stylian to become a member of the association again?
Big change.
Can you be specific, George? What kind of changes would you like to see? Not so much I mean, we can talk about personnel if you'd like, but that's not what I'm interested in. More so in terms of direction. Like, what would you like to see in the peak? What would you like to see change at the peak professional
Oh,
body? What kind of
see,
changes would you like to
look,
see?
look. When I was involved, and Steve Robbins was the EO of the Australian Osteopathic Association, we fought. If the government said, "Oh, this is what you're going to do," we didn't take it lying down,
Mm,
right? We fought for the rights of our patients, and we fought for the rights of osteopaths.
yeah,
Now we're getting handed down, whatever AHPRA says, or whatever Friends of Science say, we get that handed down to us. And it's like, we've become another government department that just says yes.
mm,
That, and sometimes we say yes because we agree.
mm,
We do not agree as a profession. And obviously there's a lot of people out there. If we've got 25% of the population of the professional people, involved with the association drop out, well, that means that there's a lot of people that don't agree.
yeah,
So, and the other thing I feel is that we need a body that will unify the profession, because the
mm,
profession hasn't been unified for a very long time. And we're drifting away from osteopathy. It's like I'm not saying that dry needling and exercise physiology is no good, but a lot of people are moving down. A lot of osteopaths are moving down that path
mm.
without having first discovered the path of osteopathy, the
Yeah,
path
and the
down to us.
Yeah, the path of osteopathy, I think, from what you're saying, and correct me if I'm wrong, it's more about the thought process. I mean, you can use a needle to treat somebody, you can use exercise to treat somebody, but you can also put that through the osteopathic lens. You can look at it from an osteopath's perspective and
Yes,
understand what you're trying to do in terms of structure and function. They're looking at the self-regulatory and self-healing mechanisms of the body, looking at the anatomy, understand having a deep appreciation, understanding for anatomy, physiology, and also the spirit of the person. When you have that in place, you could use dry needling, you could use physiology, you can use cranial, you could use HVLA, you could use all these tools and bring them together and have a really good approach for your patient. From my understanding, that is that what you're trying to say, George? Like, does that sum it
yep,
up pretty? Yeah.
yep.
And to kind
So,
of, I guess, double down on what you've said, look, my particular feelings is that there was a lot of headway made and I've this is just through conversations that I've had. It seems like a lot of the things that we take for granted today as osteopaths were given to us by people who really fought very, very hard for that. And
yeah,
then I think what happened is that the association or the peak professional body probably needed some better systemization, some organization, and have some processes put in place as the profession grew, as the university started to put out more students. And along the way, we've lost the essence of that fight because we've really moved away from what it is that makes us osteopaths. And I think now we're at another juncture in our particular journey as a profession, as a profession, where we need to get the bit of that fight back. What I'm seeing out there is that we're fighting for crumbs that we shouldn't be. Like You know, we're scrapping for an extra $3 on the Medicare rebate. You know, like, really good practicing osteopaths do not give a crap about an extra $3 on a Medicare rebate because they've got a waiting list of patients that want to see them because they're doing great work.
Exactly right.
You know, we're fighting for, recognition in NDIS, and that's great. There's nothing wrong with that. Get recognition, but get recognition as osteopaths, not under some kind of other allied health or other.
We should be putting our efforts into research that shows osteopathy works.
Yeah.
Not putting it into, explaining how it works.
Yeah. Well, I think
it works differently with every patient. So,
right.
It's like what we've got to do is show them this works.
Yeah. The age of organization and process and systemization, I think is over because it's, we've got artificial intelligence for all that now. There's technology for that does all that for you. I think we need to go back to having a bit more of a fighting mentality as an association. We need people there that are going to, expand the profession, have more courses available in major cities like Sydney and Adelaide that are really crying out for courses. And we need to go back to fighting for what we want, going after it, not just waiting for it to come to us.
Yeah, exactly.
That's been my particular problem with it. I'm still a member of the association because I think it's better to, I guess, be inside and try to make change. But who knows? I'll make it to where you are one day, George, and just be worn out by it. But George, I want to thank you for your time. This is the second.
You're most welcome, and thank you for, wanting to hear me out.
Mate, always. I think I'm definitely going to hit you up for part 3 and part 4 down the track. I'd like for you to be somebody that we continually talk to so we get your views and opinions on things. And this is one of the reasons why I set this podcast, because outside of, I guess, the association or the Osteopathy Australia, there wasn't really an Australian-based podcast that had people on there that could talk freely about osteopathy, whether it's being in private practice and clinical practice, or through regulatory frameworks, or through, professional body organizations and so forth. So I wanted to give people that opportunity, and there's no better person to give that opportunity to than you, George, because you've been there from an early time, and I really appreciate you taking the time to be with me today.
Thank you.
All right. So for all our listeners, sorry, buddy.
Keep up the good work. You're doing great stuff. I think what you're doing is really, such an asset to the profession.
Thank you, mate. Thank you. That means a lot. For everyone that's listening, this will be the end of the podcast. So thank you for joining me. George, stay on the line. We'll continue our chat. But for everyone else, have a good evening.